Welcome, everyone. This is a session about inflammatory myopathies, new treatments, and I would like to welcome our speaker as well, who is Professor Olivier Benveniste. He is a professor of internal medicine, and he works at Hospital of Pitié-Salpêtrière in Paris, France. And without further delay, Professor Benveniste, please go ahead.
Thank you very much, Pedro. My pleasure to be here today. And we will start with classification of myositis, because really to speak about new treatment, classification matter. And as you know, most of the literature is based on these binary classifications on polymyositis and dermatomyositis coming in the mid-70s. Saying that if you have a myopathy, a girdle myopathy with inflammation in the biopsy, high CK levels, a myogenic change on the EMG, then you have a polymyositis. And if you have, in addition, some typical signs of dermatomyositis, skin rash, then you have a dermato. But 20 years later came this other subgroup of patients called the inclusion body myositis. And we will talk later in my presentation of the criteria to define this subgroup of patients. And almost at the same period also was described the antisynthetase syndrome. And more recently came one fourth subgroup of patients called the immune-mediated necrotizing myopathies, described for the first time during this ENMC workshop. We will come also later on that. And finally, the last classification criteria came from the group of Ingrid Lundberg. She got a huge grant from Europe to refine the classification criteria, and this is a good criteria to classify patients among neuromuscular disorders as having one myositis. And among myositis, at that time she started the classification system. She was not able to use many myositis-specific autoantibodies, only anti-G1. That makes that at the end of the day, she only can subclassify myositis as dermatomyositis, sometimes juvenile, depending on the age of the patients, polymyositis, and inclusion body myositis. But in parallel came, years after years, the discovery of all these myositis-specific autoantibodies. Some of them are specific to the different subgroups of myositis. And the great revolutions came from the fact that we can easily make the test in routine in every hospital immune lab to have to test these different myositis-specific autoantibodies. You have here two brands, and they are quite good in terms of sensitivity, specificity, and so on and so forth. So, for instance, here, this patient is an anti-MDA5 positive. So, knowing that, I asked to my PhD student, Kuberaka, to perform one unsupervised hierarchical clustering analysis, starting from roughly 350 myositis patients with all these myositis-specific autoantibodies. And the big computer can say that this is all these myositis patients is not one homogeneous group of patients, and that we have four subgroups: dermatomyositis, antisynthetase syndrome group, immune-mediated necrotizing myopathies, and inclusion body myositis, which is not far from what we write some years before, just based on the observation of the patients and the presence of the autoantibodies. And we propose that we can classify the patients in four subgroups. The first one is the one I called overlap myositis, because it is overlapping with sclerodermia, particularly by the presence of interstitial lung disease, arthritis, renal phenomenon. And you can find also the autoantibodies but specific or linked frequently with sclerodermia, such as PMSCL, RNP, CAIU, but also the subgroup of patients with anti-synthetase autoantibodies. Then you have the group of dermatomyositis with all these specific autoantibodies. The group of immune-mediated necrotizing myopathies with two hallmarks, which are the presence of anti-SRP or anti-HFGCR autoantibodies, and the group of inclusion body myositis. So coming back to the old classifications, using Peter and Bowen, you can see that polymyositis is in fact the unifications of overlap myositis, immune-mediated necrotizing myopathies, and inclusion body myositis. And this group, led by Marianne de Visser, already wrote that polymyositis was one overdiagnosed entity, and particularly because in the same journal, Tony Amato said that polymyositis at the end of the day is a sort of unicorns and mythological beast. Coming back to the more recent Myositis EULAR myositis classifications, still polymyositis regroups, in fact, overlap myositis, what I call overlap myositis, and immune-mediated necrotizing myopathies. So coming back to the main purpose of this topic, which is the treatment of myositis, we have to look in the literature, and before 2013, only 10 randomized controlled trials was performed for what we call adapic polymyositis and dermatomyositis. You can see here the different study with the different drugs tested. And at the end of the day, as it has been outlined by this Cochrane database study, all these studies had a lot of bias. So it was difficult to draw any clear conclusions on the best efficacy of these different drugs. In 2013 came this very important trial on 200 myositis patients, refractory to conventional treatment, meaning corticosteroids plus methotrexate. But it was difficult to draw any definite conclusion also because of the design of this trial, since there are only two arms, one with the conventional treatment plus rituximab, and the second with placebo. But after 2 months, then the rituximab was added. 1/3 arm is lacking with only placebo all over the time. Because at the end of the day, there are no differences in terms of efficacy between the two groups, the two arms. And finally, to my opinion, the best today well-done clinical trial was devoted only to juvenile dermatomyositis and published recently into the Lancet. And even if this trial is for very rare disease and a very homogeneous group of patients, that is also the strength of this study, it can be able to compare three drug approaches. The first was with prednisone alone, the second with prednisone plus cyclosporine, and the third prednisone plus methotrexate. And at the end of the day, the efficacy was better for the combinations of prednisone plus one immunosuppressive drug, and because the side effects of methotrexate was less important than with cyclosporine, the conclusion of this paper is to use for dermatomyositis the combinations of prednisone plus methotrexate. So it was really a very important step behind. That makes that today we can recommend, once again, it's my opinion, it's my expert opinion, but I think I can share it with many of my colleagues. So for the treatment of dermatomyositis, what I call overlap myositis and immune-mediated necrotizing myopathies, all of them called previously polymyositis, the first line is prednisone at 1 milligram kilo per day, plus one immunosuppressant, which might be methotrexate or sometimes azathioprine. And if the patients are severe, you can add IVIG, I mean by severe swallowing troubles or bedridden, things like that. But of course, we need much more larger controlled trials. For instance, what is the place of biotherapies like rituximab? In the RIM study, when subgroup of analysis of the subgroups showed that maybe rituximab is better for anti-GO1 positive patients, anti-MI2 or anti-SRP, and where the place of JAK inhibitors, it's still under debate. So I come back to my classifications, because once again, classifications matter in terms of physiopathogenesis and at the end of the day, in terms of treatments. And I can start with immune-mediated necrotizing myopathies with anti-SRP or anti-HMG-CR antibodies. So Eva and Bag from my group have shown some few years ago that on the biopsies of patients with anti-SRP or anti-HMG-CR, that's exactly the same, we can observe some deposits at the surface of the fibers of the C5b9, which is the terminal compound of the complement activations. And is it coming from the classical pathway or the alternative pathway of the complement? It perform also immunohistochemistry using antibodies against the C1q, which is the hallmark of the classical pathway. And you can observe also, as you can see here, IgG deposits at the surface of the fibers of immune complex. And even if we perform some purifications of anti-SRP or anti-HMG-CR coming from patients, we can observe some fibers decorated by these patients' autoantibodies on the biopsies of the patients. So we have the feeling that, in fact, the deposits of the immune complex, anti-SRP or anti-HMG-CR, activates the classical pathway of the complement. And Olivier Boyer, who is immunologist in Rouen, performed some in vivo experiments. This time he just performed some passive transfer of anti-SRP or anti-HMG-CR to the mice coming from plasmapheresis of patients. And in mice receiving these purified immunoglobulins, SRP or HMG-CR, you can see that their strength was lower. And also in the pathological ground, we can observe some necrotic fibers and complement deposits at the surface of the myofibers. So that makes that today we propose these physiopathogenic events in immune-mediated necrotizing myopathies, where these autoantibodies, the anti-SRP or the anti-HMG-CR, can find their target at the surface of, in fact, regenerative myofibers, then activate the classical pathway of the complement and lead to necrosis, but also atrophic phenomenon, and also impair regeneration. I don't have enough time to show you this part of the study we performed in vitro. And this is very near from what we know from the myasthenia gravis, where I remind you that we have some anti-acetylcholine receptor autoantibodies, which can find their target at the level of the muscle fibers at the end plate, activate the complement. And now anti-complement strategy get the authorization of use. And I think that we are in a very similar situations. That makes that we started with others this phase 2B trial for immune-mediated necrotizing myopathies using this molecule, which is an anti-complement small molecule to block the complement activations. So this trial is now ongoing. But regarding today, what we can use, we had recently this workshop with colleagues in Holland, and we proposed this strategy to treat immune-mediated necrotizing myopathies. First of all, as usual, we start with corticosteroids at 1 milligram kilo per day, and during 1 month, and then you can taper the dose, and you add 1 immunosuppressant with slight differences between anti-SRP and or anti-HMBCR, since for anti-SRP, rituximab seems a little bit more efficacious than immunoglobulins, polyvalent immunoglobulins, IVIG. And for severe cases, we can use plasmapheresis, IVIG, and in combinations with methotrexate, for instance. So moving back now to the dermatomyositis and all these autoantibodies. I remind you that you have this typical rash with the heliotrope rash, the Gautron hand, and so on and so forth, and also some pathological hallmarks that make the diagnosis relatively easy if you have all these signs, pathological signs, and one of the autoantibodies. And Steve Greenberg was the first to show that on the muscle biopsies, you can see that by arrays with omics approaches, you can see that many of the mRNAs of the pathway of defense viruses, the pathway of interferon type 1, are really highly activated compared to the normal muscles. And at the protein ground, you can also observe the same things in the biopsies of patients where all these proteins linked to the interferon pathway of defense, non-specific defense against the viruses are highly activated. We, but many others have shown by different technology here. This is by CIMOA, a very sensitive way to measure interferon type 1 alpha in the sera of the patients. We can observe that there is a good correlation in dermatomyositis patients between the levels of interferon and the activity of the disease, and also that under treatment, you decrease the interferon signature. So that makes that maybe it will be interesting to block the interferon pathway. So you have different ways to do that. First, you can use one monoclonal antibody against interferon, but there are at least 13 different interferon alpha, so that is difficult. You can block the receptor of the interferon, or downstream, you can block the JAK1 and JAK2 that permit the translocation of the signal to the nuclei of the cells. And this is why we tested first in vitro, and Leandro did that in my lab, the effect of JAK inhibitors on one in vitro system of muscle culture. And if you cultivate your cells, you add interferon or a different kind of interferon, then you have poor cells at the end of the day with no fusions, very atrophic, and so on and so forth. And if you add one JAK inhibitor, then you restore totally the phenotype of your cells. So based on that, we started to treat dermatomyositis patients refractory to any conventional drugs. And after only 3 months, we can observe that the C-DAISY, which is a marker of skin activity, clearly decreased, and also the interferon signature normalized. So that's the reason why we will start even and back what the PI of one clinical trial, which is still not ongoing, but we get them funding to do that. But we are not the only one. Different teams in the world will test the JAK inhibitors. Here we will treat our patients with corticosteroids and baricitinib or placebo. Moving to the antisynthetase syndrome, I remind you that it was described in the 19th, and this is the association of myositis, interstitial lung disease, Raynaud phenomenon, mechanic hands, and arthritis, with the presence of anti-GO1 or the others, and we can in routine test anti-PL7 or anti-PL12. So the main problem during these conditions is that makes the prognosis is the severity of the interstitial lung disease. And there are two schools over the world, the American, Japanese school, and our colleagues are more keen to use tacrolimus to tackle the interstitial lung disease, and the European school, where we use more frequently cyclophosphamide in bolus. So we will start in September. Because of the COVID, we have to delay the first patients, but we will start in September for patients with antisynthetase interstitial lung disease in 88 patients, these trials comparing these two approaches. And to finish, I would like to have a few words on inclusion body myositis. So just to remind you that really, if you use the Peter and Bohan criteria, all patients with inclusion body myositis will be classified.
Yeah, otherwise it's difficult for me to listen to you. And
pardon me? Okay, so if you apply the Peter and Bohan criteria, then you will classify the IBM patients as having one polymyositis, and that is not a good idea because, as you know, these conditions is very resistant to the corticosteroids, and so the criteria are not so difficult to recognize and to test on the patients. First of all, the patients are older. It's more frequently men. In average, the disease starts at the 6th decade of life, and the steady state is around 70 years old. So if in front of patients with an inflammatory myopathy, you have finger flexors or quadriceps weakness, as you can see here, the atrophy and the finger flexors are very weak most of the time. On the biopsy, inflammations within the muscle and invited fibers or the presence of ring vacuoles. So you have all the characteristics here. Then it is not a polymyositis, it is one inclusion body myositis. So it's a weird disease with two compounds. First of all, one clear inflammatory reaction, but also one degenerative part with autophagy problems, dysfunctions, and accumulations of misfold proteins, mimicking somehow the Alzheimer in the brain. And what we propose, because we are many, and particularly Steve Greenberg, first we observe that in IBM patients compared to other myositis, as we published it recently, we have one accumulation in the peripheral blood of highly differentiated CD8 cells, which are called TIMRA cells, the same cells that you can observe during chronic viral infections such as HIV infections. And if you can characterize these cells, you have different markers, then you have a good, it might be also a good diagnosis test to distinguish inclusion body myositis to the other myositis, and particularly what we call previously polymyositis. So these cells are keen to secrete a lot of interferon type 2, gamma, that leads to different things, and particularly mitochondrial dysfunction, and also some endoplasmic reticulum stress that leads to the presence of autophagy vacuoles full of unfold and misfold proteins which aggregate. And for different reasons, rapamycin seems interesting to be used because it can block the TIMRA cells. Rapamycin is used normally to prevent kidney graft rejection, but also rapamycin has interesting effect on mitochondrial dysfunction and also on autophagy. So that's the reason why we tested rapamycin. But today, the recommended treatments is almost nothing, since the only interventions which can make some benefit to the patients is the physiotherapy. In fact, the more the patients do exercise, the less rapidly the disease progress. Of course, sometimes the diagnosis is difficult. Sometimes it is mimicking a polymyositis at the very beginning of the disease. And sometimes conventional treatments are working. So if you have a young patient with a rapid evolutions, with a lot of inflammation within the biopsy, you can test conventional treatments with prednisone and methotrexate. But after 3 to 6 months, if you don't have any efficacy, then stop your treatment. And if you have swallowing troubles, IVIG can be effective, or also cricoid myotomy. But as I said, we perform, and the paper is now submitted, one randomized double-blind placebo-controlled phase 2b trial, pilot trial, in fact, where the main outcome was not significantly different. I have to say that clearly. It was the measure of the strength in the quadriceps after 1 year of treatment. But on many secondary outcomes, we have probably a good signal. For instance, in the 6-minute walking distance, you can see that under rapamycin, the patients remain stable. So it has nothing to do with muscle strength, and you cannot improve the strength of the patients. But on the placebo group, you can see the decline, and the differences are significant. This is the same for this HAQ, which is a scale of handicap, increasing in the placebo group and remain stable. But also we perform QMRI, quantitative MRI, to see the fatty replacement of the muscles. Here, for instance, so we report it is significant in the wall when we normalize all the muscles. But for instance, here in the quadriceps, you can see that the fatty replacements increase in the placebo group and remain stable under rapamycin. So to conclude and to come back to this classification, I think that tomorrow we will have, if all these ongoing trials are positive, different options linked, in fact, to the different physiopathogenesis of these different subgroups. So for dermatomyositis, certainly JAK inhibitors or strategy tackling the interferon type 1 pathway, such as monoclonal antibody against the receptor of interferon type 1, might be certainly interesting. Regarding immune-mediated necrotizing myopathies, you can tackle the cells producing the anti-SRP or the anti-HMGCR, maybe with the new drugs of the multiple myeloma. That might be something interesting. or with an anti-complement strategy. And as I said, this trial is ongoing. Regarding the antisynthetase syndrome, to tackle the interstitial lung disease, this trial is ongoing, comparing tacrolimus to cyclophosphamide. But here, maybe the rituximab is also interesting, but we need further trials. And finally, for inclusion body myositis, for the first time, maybe we have something making a little bit better than the placebo, which is the rapamycin. So I thank you for your attention, and this is the team of the young researcher working with us. Thank you very much.
Professor Machado, can you hear us? Hello?
I can't see anybody. Do you hear me?
Neither. No, I don't hear him. Professor Machado, you need to unmute yourself, maybe.
Yeah, can you hear me now?
Ah, yes, now it works.
Okay. So thank you very much, Olivier. That was a great presentation and very informative. We have several questions. I'll try to go through some of them. So Olivier, in terms of IVIG, there's one question. For how long do you use it? And how do you space the dose after a while? How do you do it?
Yeah, so first of all, I use it only for the most severe cases, in the exception of immune-mediated necrotizing myopathies with anti-HMGCR. For the most severe cases, I mean by severe by swallowing troubles, or really patients with high difficulties to walk or to climb a stair, I use 2 grams per kilo per cure every month, and I use it for 3 to 6 consecutive times. So that means 3 to 6 months. At the end of this delay, if patients recover pretty well, then I stop it, sometimes totally, sometimes using, when the case was particularly severe, half dose for a while, and then I stop it. But it's not for the long term, except some rare patients with anti-HMGCR autoantibodies, where sometimes this is the only drug effective in the long term, with the high dose of corticosteroids. But because we don't want to maintain it for so too long, sometimes we have to maintain patients under IVIG.
Good, thank you. And what do you think is the best treatment strategy for patients that are positive for MDA5?
Yeah, it's a good question, because it's the more severe among the myositis, among all the myositis. We have one, yes, we published yesterday or the day before, one series of 136 MDA5 patients in neurology. And we can observe, as in lupus, some very mild form of the disease with only arthralgia and skin lesions. So for this very mild MDA5, small MDA5, I would say, you can use small dose of corticosteroids plus methotrexate, for instance, and that's enough. And to the opposite, we have a catastrophic MDA5 syndrome with 60% of deaths due to rapidly evolutive interstitial lung disease. And for those patients, it's very difficult to treat them. So you have to avoid to have your patients in intensive care units, because once they have the tube, then they will die at 100%. So for those patients, we use plasmapheresis, bolus of high dose of corticosteroids, cyclophosphamide, JAK inhibitors, all together. And between these two extreme situations, you have one intermediate subgroup with it's more main, with more myopathic, and a lot of arthralgia and skin lesions too. And for those patients, I would say we use the conventional treatments with corticosteroids, methotrexate, IVIG sometimes. But also, this is where we can observe the highest interferon type 1 signature, and we more and more we use JAK inhibitors also in this situation.
Yeah, and there's a question about starting immediately with a combination of steroids and rituximab, or steroids and IVIG. Are there any situations where you'd recommend that?
Yes, clearly when the patients are severe. Once again, I think it's my opinion, and only my opinion, and other colleagues prefer to start with corticosteroids alone because some patients will not relapse. But it's so frequent with certain autoantibodies that, to my opinion, I recommend to start with the combinations of corticosteroids plus methotrexate, and if your patient is severe, to add IVIG at the beginning. And for some subgroups, you can discuss the interest of rituximab, particularly for anti-GO1 patients, anti-MI2 patients, and also anti-SRP positive patients.
There's a question also about any correlation between antibody titers and treatment response.
Yes.
Although I don't think we often get antibody titers, often we only get a positive or negative result, but would you like to answer that question as well?
Yes, that's perfectly right, because in routine we have dot lines and it's not quantitative, but some tests are ELISA or others that you can perform in your research lab are quantitative. And there are some correlation for some autoantibodies. We published, it's well known that anti-SRP and anti-HMGCR are correlated with the severity of the disease. That's also the case with anti-MDA5, and also you can decrease by the treatment the titer of these antibodies up to they will be undetectable after a while, particularly the anti-MDA5. Anti-GO1, there is a clear publication on that, and probably there is a small correlation, but less important, and the titer almost never will not become negative.
There's a question about lenabazum, and for those who don't know, this is a small molecule. It's an agonist to the cannabinoid receptor type 2. I'm not sure if you mentioned it or not. Do you have any comments about that potential treatment?
No, because I was not implicated in the trial, so I haven't seen the results of the trial, and I have no experience.
Perfect. Doses of IV methylprednisolone, usually which doses do you use?
For prednisone or prednisolone?
IV methylprednisolone. Do you use 1 gram?
Yes, for the severe cases, yes. It depends of your patients, between 500 to 1,000 milligram, frequently 3 times consecutively, 3 different days.
Okay, and maybe a couple more. Interstitial lung disease. What's your preferred regimen for that, associated with myositis desynthetase syndrome?
Yeah, as I said, we will test the two options. We started with always corticosteroids, methylprednisolone plus bolus of cyclophosphamide. This is in what we use usually for the severe cases. For the milder cases, I like, instead of cyclophosphamide, mycophenolate mofetil. But I don't know if one is better than the other. And for extremely severe cases, and particularly patients in intensive care units waiting for pulmonary engraftment or death, I would say, sometimes we perform combinations of cyclophosphamide plus tacrolimus.
Excellent. And maybe a couple of more. For severe skin disease, TIF-gamma positive, non-responsive to rituximab and IVIG, any treatment options?
Jakinibs.
Okay.
It's working very well on the severe skin lesions, particularly well.
Very good. And are all JAK inhibitors the same?
I don't know.
Yeah. Yeah, we don't know that. Okay, I think we don't have time for more. I would like to thank you very, very much. I think this was a very elucidative session, and I thank everyone for attending it. Thank you very much.